Today I'm going to talk about the dental consideration in Down syndrome. Not a lot of dentists are here, therefore I will try to make it as simple as possible because many dental items or terms, they are not well known by you, so I'll try to make my lecture as simple as I can. We all know that Down syndrome is a chromosomal disorder due to 3 copies of chromosome 21, leading to a classic clinical feature with varying degree of mental retardation, varying from mild, moderate, or severe. In my lecture, I'm going to concentrate on 3 main areas or topics in dentistry. First of all, the oral finding that we can see in Down syndrome, medical conditions that have dental implication, and finally, how to treat and manage the Down syndrome child on the dental chair. In the oral finding, we're going to cover the dental caries, periodontal disease, and malocclusion. These are the main 3 important areas that we can discuss. First of all, the dental caries. All dentists are concerned about dental caries. Also, the parents are always concerned about their children's health and especially infection with dental diseases, dental caries. Regarding Down syndrome, there are 2 different debates. The first one stated that Down syndrome are not liable to get dental caries as normal children. They have less or lower incidence in dental decay than normal children. And many studies have supported this debate. Why? There is a reason. First of all, in Down syndrome, the teeth are usually small in size with a big interproximal spaces. And when I say interproximal spaces, if this is a tooth and this is the neighboring tooth, this is the interproximal space. So if you have a small teeth, you have a big interproximal spaces. When we have a big interproximal spaces, this means that the food and the debris and plaque is easily removed from this area. This will prevent the proximal decay that comes from the side of the teeth. So we can say that this is a self-cleansing area. The second reason is that the occlusal surface, and the occlusal surface means the occlusal grinding surface, the surface of the teeth where we grind the food on it. This surface usually have pits and fissures and grooves. If the grooves and the fissures are really deep and narrow, then the food becomes retentive and the dental plaque becomes very difficult to remove. Fortunately, that in Down syndrome, we have a very shallow pits, fissure, and groove, and this will allow for the self-cleansing mechanism action of the dental plaque. And this will lower the occlusal decay, which compromises around 60% of the caries affecting children. The last point is the delayed eruption of the deciduous teeth and the permanent teeth in Down syndrome. If a normal child will erupt his primary teeth, his baby teeth, at 6 months, we will find that the Down syndrome will erupt his teeth about 9 months or 8 months. And if the normal child will erupt the permanent teeth at 6 years, we will find that the Down syndrome will erupt their teeth at about 8 years of age. This will postpone the onset of the dental caries. At the same time, when the unerupted teeth stay a longer time inside the bone, the enamel, which is the outer surface of the tooth, will gain more calcium and become more calcified and more resistant to any caries attack when it will erupt. So these are the 3 reasons why we have a low incidence of caries in Down syndrome. However, unfortunately, other studies prove that Down syndrome has a more incidence of early childhood caries than normal children. And when I say early childhood caries, it means that the caries that affect infant and toddlers, the age is between 1 year to 4 years. And the main reason for this caries is the delayed weaning of the bottle, that the child will keep taking his milk from the bottle up till 3 years of age. In normal children, and it's always recommended that when the child is 1 year of age, he has to stop taking the bottle and he has to take the milk from the cup. If the bottle is continuous for a longer time, after 1 year till 3 years, then this will lead to a severe acute type of caries. Why? Because the milk is formed or contain lactose, and lactose is a mixture of glucose and galactose. Glucose is a polysaccharide. It's the favorite nutrient for the cariogenic bacteria, Streptococcus mutans. So if we give glucose, then the bacteria will flourish and it will attack the tooth surface. So the question here is, what's the difference between taking a milk in a cup and taking a milk in a bottle? There's a big difference. When the child is taking the milk from a cup, then he will finish the cup in about 5 minutes. And 10 more minutes is needed by the saliva to wash the action of the milk. But when he takes it from a bottle, then this time is so much prolonged. He will finish it within 15 minutes, for example, and it will take about 30 minutes for saliva to clean this action. And so you are giving more time for the bacteria to attack the teeth. And this is it becomes worse if the child is taking the milk several times a day, and worst of all if he's taking it at night, because at night there is no saliva. The saliva becomes minimum. So you are taking off this washing action of saliva, and you are giving milk. The tooth all night becomes soaked in this milk which contains glucose, and so the saliva, and so the bacteria will flourish and will severely attack the teeth, giving a severe form of acute caries. So the delayed weaning of the bottle is the main cause why we find the early childhood caries in Down syndrome children. The second thing is that it is very difficult to maintain a good oral hygiene. It is difficult for the parents to clean the child teeth with a toothbrush and a paste. Even if they are trying their best, sometimes the child is not cooperative, they're not opening their mouths widely, they cannot reach to the posterior teeth, which make it very difficult to maintain a good oral hygiene. This is the second point. Also, that usually the first dental visit is delayed. The parents doesn't seek the dentist until there is a problem, there is pain. And so there is nothing we do about prevention. The patient already has caries and we see him at that stage. And lastly, that the children with Down syndrome are usually rewarded by parents or by caregivers. They are usually rewarded, unfortunately, by sweet. They take chocolates, they take candies, so this is another cause why there is always polysaccharides in their mouths and the saliva become full of the Streptococcus mutans. If I have a Down syndrome child with dental caries, how am I going to treat this dental caries? Well, we have to be aggressive. We have to provide a very long-lasting, durable restoration, because it is not easy for us to make the child sit on the dental chair and to give the treatment. Sometimes we need to go to general anesthesia. Therefore, if I'm going to treat, I have to give a long-lasting and a very durable restoration. So if we have a wide restoration, it is always better for us to do stainless steel crown. This is an example of stainless steel crown. This crown is made of stainless steel, and it covered the whole tooth structure. It's very durable, and it lasts until this primary tooth exfoliate and the permanent come. So it's better than amalgam and composite to put stainless steel crowns. And if we have a deep caries like this one, then we go immediately for root canal treatment to remove the pulp of the primary teeth, and we cover it again by the stainless steel crown, as we can see here. If we have any abscessed primary teeth, that there is pus and purulent secretion, then we go immediately for extraction. We remove the tooth, and we have to put immediately what we call a space maintainer. This space maintainer is very important to maintain the space for the permanent teeth to erupt. If we didn't put it, then there will be space loss, and the permanent teeth will not find space to be placed. So what I want to say is that we have to give a radical treatment, long-lasting restoration. The second thing is the periodontal disease. What is the periodontium? What do you mean by periodontium? The periodontium is the soft tissue that covers the tooth. So it is the gum that covers the teeth in the oral cavity, and it is the periodontal ligament which hold the root of the teeth to the bone. As you can see in this X-ray, this is the root. There is a very thin 1 millimeter radiolucent space, and then the bone. This is the periodontal ligament. This periodontal ligament is very important. It is the reason why the tooth is strong in its socket. If this periodontal ligament is affected, then the tooth will become loosened and we will lose it. Okay, so the periodontal disease is a disease that affects the gum or the periodontal ligament. Usually, the periodontal disease is not a disease of children. It is very rare to find a child with periodontal disease. Periodontal disease is usually acquired as we go older in age. But unfortunately, in Down syndrome, there is a very high incidence of the periodontal disease, reaching to 90% or 96% of Down syndrome can develop periodontal diseases. And this is due to the defective in the immune system due to the chromosomal defect. So the immune system of these tissues are not strong enough to withstand any bacterial invasion from dental plaque. So if a normal child has some plaque on his teeth, the periodontium can resist the bacteria. But in the Down syndrome, it is very weak, and so the bacteria will attack aggressively. In this picture, I'm showing the difference between the normal gum. We see that the gum is pale pink in color. It is fibrous, and it has a sharp margin. In this picture, this is acute inflammation of the gum. We see that the gum is red, inflamed, fiery red in color, and here we see the rolled margin, round rolled margin. This indicates inflammation of the gum. So this is acute inflammation. On the other side, what about the periodontal ligament and bone? This is a perfect normal periodontal ligament and bone surrounding the whole root surface, giving a strong attachment, strong teeth, healthy teeth. But here, we can find that the bone is already lost. The first thing is the periodontal ligament inflamed, and then the inflammation will go to the bone eventually lost, and the tooth will eventually be lost. So the main cause for the periodontal disease in Down syndrome is the lowered immune system of the periodontium. The second thing is inability to maintain good oral hygiene. As we said before, it's difficult to clean their teeth. And number 3 is the poor masticatory action. What does this mean? We have oral muscles which are very important. These are the cheek muscles, lip muscles, and the tongue. If we have a strong muscle action, these provide a self-mechanical cleansing in all of us when we eat. These muscles will automatically clean the surfaces of the tooth from the food debris. But unfortunately, in Down syndrome, they have hypotonic, low tonicity of the muscle. And therefore, this cleansing action is not present, and the food debris is present for a long period of time on the tooth surfaces. And lastly, is that Down syndrome are mouth breathers. So when you have a mouth breathing, what happens? The child is opening his mouth all day. There is dryness of the saliva. And saliva is a very important protective film. So the dryness will occur mainly in the upper anterior region, and the gum will become inflamed immediately. These are the reasons why the periodontal disease occur in Down syndrome. What is the progression of the periodontal disease? The first stage will be acute inflammation of the gum, as we've seen before, red inflamed gum, severe pain, patient will refuse eating, and if he will eat, he will not chew, he will directly swallow. And then after that, we'll go to the chronic phase, which is more dangerous because in this chronic phase, there is gradual destruction of the periodontal ligament and destruction of the bone around the tooth. How will I manage the periodontal diseases? We have to do aggressive scaling to remove the dental plaque, and we give antimicrobial agent. The best is the chlorhexidine. We can give it in different forms. If the child can expectorate good and above 7 years of age, we give mouthwash. If he cannot, then we give sprays or gel. Malocclusion. Malocclusion is a very important finding in Down syndrome again. If we look at this slide, we will find this patient, normal patient. We will see the profile, perfect profile, straight profile. Why? Because there is proper proportion between the upper jaw and the lower jaw, giving this straight profile. But if we look at this slide, we will find that the lower jaw is much more protruded than the upper jaw, giving what we say as concave profile. This concave profile, in dentistry, we say it is class 3 malocclusion, meaning that the mandible is much more forward than the maxilla. This is not due that the mandible is growing more than normal. No, the mandible is normal, but the defect is in the middle face. There is middle face underdevelopment in the premaxilla and the nasal bone. So that's why we have a class 3 malocclusion. Another cause for malocclusion is the inequilibrium of the oral muscle action. The dental arch is not static, it is dynamic, and it is affected by the oral muscles. So if the oral muscles, which are the cheeks and lips and tongue, provide equal forces, we will have the perfect arches. If there is any inequilibrium between these forces, we have malocclusion. To make it more simplified, the cheeks and the lips always tend to constrict the upper arch. The force comes outward, inward. What opposes them is the tongue from inside. The tongue will push the maxilla outward. If we all try to swallow now, you will feel that the dorsum of the tongue is pressing on your maxillary arch. This provides a positive force on the maxilla to take the proper shape and size. What happened in Down syndrome? We can see this patient. This is the classical picture of Down syndrome. A short hypotonic upper lip, so the action of lip is missing. What happened? The child is always opening the mouth. He cannot seal his mouth, so he's opening the mouth, and so he will breathe from the mouth. This posture, what does it do? Where is the tongue? Is it supported by the maxilla? No, it's away from the maxilla. So the positive force of the tongue on the maxilla is already taken. And what happened to the cheek muscle? As we open, or this position provide more tension from the vaccinator on the maxilla. So instead of having a wide round maxillary arch, it will become constricted, goes up, giving a high palatal volute and V-shaped arch. This is due to the abnormal muscle action. So what is the end result? The end result, this patient, we can see here, this is a very deep palatal vault and constricted maxillary arch. As he grows, this will be the final picture. This is the normal occlusion. This is the final picture. Constricted maxillary arch posteriorly, meaning that the mandible become wider than the maxilla posteriorly, not only anterior like the previous slide, but posteriorly also. And we will have an open bite, meaning that the teeth cannot reach occlusion with each other. And this is due to the continuous protrusion of the tongue that prevent the teeth from complete eruption. So this is what we get as we have inequilibrium in the muscle action. Other dental finding, not so important, but we have to mention it. The tooth could be small, as we said before, small in size, microdontia, and also abnormal shape or morphology. These are abnormal peg shape or pointed conical teeth. We can see this, not so much, but sometimes we see it. We said before that we have delayed eruption in deciduous and permanent teeth. Oligodontia, meaning that some teeth might be absent. They are congenitally absent, not formed. And on the other hand, sometimes we already have extra teeth, what we call as supernumerary teeth or mesiodents. So the number of teeth, we can have oligodontia or we can have excess teeth, supernumerary teeth. Erosion. Erosion of enamel, this is very important, and this is due to medical condition, which is esophageal reflux. This patient, if he has esophageal reflux all the time, the gastric content reached to the oral cavity. It is very acidic, about 1.5 pH. This will lower the acidity in the oral cavity so much that this acid will start to erode the enamel, to dissolve the enamel surface. This is what we call as erosion of enamel. Erosion means that enamel is lost due to chemical action, not mechanical or physical. So enamel erosion is due to the gastroesophageal reflex of the gastric content. What will happen? That the enamel is completely lost and the dentinal tissue is exposed. Dentine is very sensitive. What will be the symptoms? Severe sensitivity to any hot or cold stimulus. What shall we do? We have to make complete coverage of these teeth with crowns. Interior, we do composite crown. Posterior, we do stainless steel crowns. These were the oral findings. Now we're going to talk about the medical condition with dental implication. Two important medical conditions for us as a dentist: congenital heart diseases, and because 40% of Down syndrome are liable for congenital heart diseases, and leukemia, as they are more prone than normal children by 10% to get leukemia. In congenital heart disease, as a dentist, we are concerned about the subacute bacterial endocarditis because the Streptococcus viridans, which is the main pathogen for the endocarditis, is a normal inhabitant of the oral cavity. So any dental procedure that will cause bleeding, this means that I'm introducing this bacteria into the bloodstream. Therefore, I have to give a prophylactic antibiotic according to the American Heart Society. As seen in the table, we give amoxicillin is the best. We give 50 milligram per kg, and we give it 30 minutes before our treatment for any dental treatment that will cause bleeding, not for the normal restoration. What can cause bleeding? Scaling can cause bleeding. Root canal can cause bleeding. Of course, extraction can cause bleeding. If the child cannot take oral, we give injection, ampicillin, and if he's allergic, then we give other type like Zithromax, or we can give clindamycin or whatever. This is very important. As the quality or the type of treatment I'm going to provide, I have to guard against infection. So you have to be, again, aggressive and radical in your treatment. Root canal treatment is not indicated in primary teeth. We extract immediately. Permanent teeth, even root canal, is not indicated except if really the tooth is in good condition. But if there is abscess or there is bone destruction or there is root resorption, then we immediately extract to guard against future infection or focal area of infection that can endanger the child's health. In these patients, if we're going to give local anesthesia, we have to give it without adrenaline. We use the non-adrenaline type of local anesthesia. And again, it has to be mentioned that the health of the gum is very important. It has to be under preventive measure of scaling and prophylaxis. In leukemia, if there is leukemia, we are concerned about two things: bleeding due to the thrombocyte decrease number, and infection due to the granulocyte decreased number. I will not go into details, just conclusion. If we have the thrombocyte count is between 100,000 or above, we can do our dental treatment normally. If it is from 50,000 to 100,000, then we do restoration, but we do root canal, but we don't do extractions. We cannot. If it is below that, no dental treatment can be done because of the endanger of bleeding. Regarding the infection and the granulocyte count, if it is 500 to 1,000, we can give prophylactic antibiotic and do our treatment. If it is less than that, we cannot do anything, no treatment to be done. Again, dental consideration in leukemia, we are afraid of infection and we are afraid of bleeding. If we're going to treat, we have to give radical treatment. Root canal treatment in primary or permanent is not indicated except if the patient is already 2 years complete remission. Then at that time we can do root canal, otherwise we do extractions. Sometimes we have ulceration in leukemia, and the ulcers are of two main causes. Either ulcer due to chemotherapy, very painful ulcer. What do we do? How to manage? We give chlorhexidine mouthwash, sodium bicarbonate mouthwash, and we give topical anesthetic agent. If the child have ulcer due to the decrease in the granulocytes, these are infective ulcers, very deep bleeding ulcer, then at that time we have to give topical antibiotics and topical hemostatic agent like the bovine thrombin. Candidal infection is another finding in the leukemia, and this is due to chemotherapy, radiation, long-term antibiotics. We have to treat it aggressively. It's very aggressive. We give nystatin suspension, and if it is not effective, we give systemic fluconazole. Lastly, how do we manage our Down syndrome in the dental clinic? Before appointment, we have, of course, to get the full medical history of the child from the parents, and if we need to consult any physician, we have to do that before our treatment. Children with Down syndrome have no specific problem. The only problem is how to get the child to sit on the dental chair and accept the dental treatment. How are we going to do this? Down syndrome children are known to be friendly and affectionate and very kind, but the problem is that these children are very anxious and fearful from any new situation, any new people. And of course, dentistry is a new situation for them, and the dentist is a stranger for them. So this is very difficult to overcome. If you want to do behavior management, psychological behavior management, the key of it is communication. And when I say communication, what do I mean by communication? When I talk, the child understands. He listens, he understands, and he responds. This is how we get communication. If you cannot get communication, then there is no behavior management. So why is it difficult for Down syndrome to get communication? Because of the mental retardation. What is the degree of the mental retardation? Speech problem, maybe he understands, but he cannot say what he wants, so there is no communication. Hearing problem, if I'm talking, he's not listening or he's not hearing efficiently. So we have 3 problems. The most important of it is the mental retardation. Therefore, our behavior management will depend on the degree of the mental retardation. If the child is mild mentally retarded, usually these children understand very well, and we can manage them very easily like normal children on the dental chair. But if he's moderate, then don't waste time. There is no communication. We cannot try. There is no communication, therefore there is no behavior management. Then what we do, we give sedation, and the very efficient type of sedation is the midazolam. And with this sedation, we use physical restraint in order that the child would not do any risky movement that would hurt him. Or we go for general anesthesia. For myself, I prefer general anesthesia. I don't like physical restraint. I think that physical restraint can provide a bad psychological effect on the child. Anyway, it is accepted, but for me, I prefer GA. If the child has severe mental retardation, then we go directly for the general anesthesia. We don't waste our time. So, if the child is mild and we can manage him on the dental chair, what are we going to do? We have to take early appointments. The child has to be fresh and alert. So the appointment has to be in the early morning, not at the nap time and not at the night time. This is number 1. Number 2, I have to be very fast in my treatment and very efficient. So the treatment is maximum between 15 minutes to 30 minutes. Otherwise, I will lose the child cooperation because these children have a very short attention span. So you have to be very quick. We use something called as tell, show, and do technique, and this is used with normal children. What does it mean? If you go to the dentist, you have no problem. Open your mouth, you can see the injection. The dentist will put the handpiece, and you as an adult, you will accept that. But for any children, we cannot do this. We have to explain what we are going to do in small phrases, suitable language that the child can understand. This is very, very important in pedodontists because it removes the fear of the unknown. It makes the child relaxed and he knows what he's getting. So if we're going to use handpiece, we're going to say we're going to give a shower to your tooth. If you're going to put the suction, this is like a straw of a juice. We show everything, the mirror he will hold before we put it in his mouth. The only thing we don't show to the child is the injection. Never. Okay, but we can describe what he will feel. He will feel a mosquito bite, but not a prick. So you always avoid any fear-stimulating vocabulary. So tell, show, and do technique is very important. And also distraction technique. We can make the child see a cartoon, listen to his favorite music, or play video game while we're trying to fix his teeth. Another important technique is the reward technique. We have to reward the child immediately, either by gesture, tapping on the child's shoulder, or by verbal reward, and at the end of the visit, you give him a small present. This is very, very effective with all children, not only the Down syndrome children. This is one of my patients. He is mentally retarded. We gave him the local anesthesia. We placed the rubber dam. We did filling for him. He's totally cooperative. And we were using audio distraction technique. This is another child. She was mild retarded. And we use video. She was watching a video. We give local anesthesia. We placed rubber dam. She's still moving a little, but was managed, and we finished her preparation. But on the other hand, these are two examples of moderate mild retardation. At first, they seem very cooperative, but once we tried just to put the mirror, this was the final response. So we don't waste time. You cannot manage. You have to go for GA or give sedation. Finally, prevention in Down syndrome is much more better than treatment, and this part will be covered with my colleague, Dr. Sahar Fahmy. Thank you all for your attendance and listening.